Wake up, little Susie, wake up.
To sleep, perchance to dream? The average person spends about 1/3 of their lives, or 288 months, sleeping. How important is good sleep to your quality of life and health? Sleep, are you getting enough? The doctors are on call tonight.
Wake up, little Susie, wake up, little Susie.
Funding for On Call is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
and by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding provided by Dakota Care, Regional Health, the Brookings Health System, Dr. Mark Bubach with Dakota Allergy and Asthma, the South Dakota American College of Physicians, and Swiftel Communications. Closed captioning for On Call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation.
During my internship years ago, we had a patient who we shall call Mr. X, who was repeatedly admitted to the hospital with sleep apnea. He was quite overweight, a smoker with lung disease, had a short, fat neck, a recessed jaw, and the nurses in the ICU stated that he snored so loud it shook the rafters. They could see that whenever he fell asleep, his airway would close off, his oxygen levels would fall to dangerous levels, and he would turn purple. Every 2 or 3 weeks, Mr. X would come into the hospital overloaded with fluid and combined heart and respiratory failure, and repeatedly he would have to be intubated. That means a tube would be placed down the throat past the vocal cords for him to breathe. Once his airway would be open with the tube and he could breathe easily, the heart would kick in, the fluid would pour out of him, and he'd come back to life. It was 1977, and our only option to keep his airway open was to make a permanent opening in the throat or place a tracheostomy tube. Well, it saved his life. And I saw Mr. X for several years after that in the outpatient clinic, not in the ICU. In 1981, in Australia, a physician developed a less invasive way to keep airways open by reversing a vacuum cleaner blower as the first CPAP machine, which stands for C, continuous, P, positive, A, airway, P, pressure, CPAP. During the 80s, the word rapidly spread, and now we have something less drastic for people like Mr. X. And what's more, we have refined the diagnosis of sleep-related problems, developed better ways to treat the complex conditions, and there is a lot to know about when and how to use that CPAP machine. Here to help us understand the developing and fascinating field of sleep medicine is Dr. Anthony Herricks of the Avera Medical Group Pulmonary and Sleep Medicine of Sioux Falls. Thank you for joining us, Tony.
You're welcome. Thank you for inviting me.
Yeah, so you're a sleep expert, but you're trained primarily, your expertise is pulmonary medicine, right?
Correct.
You're an internist specializing in pulmonary medicine.
Yes, internist first, pulmonary medicine.
Good man, you said the right word. So let's talk about sleep medicine. That's a whole separate specialty, subspecialty from pulmonary. How'd you get into that?
Well, as a pulmonologist, part of our training is sleep medicine because of the sleep disordered breathing or the obstructive sleep apnea that people have. The field primarily took care of that problem. However, over time, neurologists, psychologists, because of narcolepsy and other neurologic problems that are associated with sleep, like restless leg movements and things like that, the College of Internal Medicine has taken over the board. So as a pulmonologist in training, you get a lot of sleep medicine.
So that's good. Now, are there special boards for it?
Yes, actually, in my last year of fellowship, which would have been about 3 years ago, my class was the last group to graduate from fellowship in pulmonary and critical care medicine that was able to sit for the sleep boards without having to go through an extra year of fellowship.
Wow. So tell me about what more than sleep apnea, you know, this obstructive sleep apnea that we think everybody has, what more is there to the sleep problem?
There's everything from the inability to fall asleep, stay asleep, the feeling that you don't get refreshed sleep, which we call insomnia. There's sleep disordered breathing. There's sleep problems associated with congestive heart failure that kind of fit in that sleep apnea group. There's restless legs, which are some neurologic conditions where people's legs twitch all night long and they don't get much sleep. There's narcolepsy, which is the disorder where you can't stay awake. There's a whole host of travel-related problems, problems of college kids going to bed too late, getting up, not able to get up early enough, problems with elderly people going to bed too early, can't get up too early in the morning. So
it goes on and on.
Yes, there's lots and lots of problems.
I just read the other day that something like 30%, I can't remember what the number, but a large percentage of people have sleepwalking or have sleepwalked sometime in their life. What do you know about sleepwalking?
Sleepwalking is what we call a parasomnia, and it's not very...
Parasomnia, not like insomnia.
Right, meaning around the sleep period or occurring within the sleep period. There's sleep eating, where people will get up and not know that they're going to the kitchen and making meals. There's
sleep eating.
Yes.
Is that called
sleep eating disorder? There's two of them. One of them is you wake up in the middle of the night because you can't sleep. You go to the kitchen, you knowingly open the refrigerator and make yourself an omelet. There's also a SHRED, I think it's called, sleep-related eating disorder, where you actually don't wake up in the middle of the night. You sleepwalk to the kitchen. You may fire up the oven, fire up the microwave, cook something, eat it, go back to bed, and wake up to the mess in the morning. So it could be pretty crazy and pretty harmful sometimes.
Yeah,
so.
You bet. What is it about eating and sleep?
There are two chemicals that they've studied that they don't really know very well that are secreted in the brain. One of them is ghrelin, the other is leptin. Those chemicals both are opposite each other. When you're asleep, one of them is secreted in the normal person, and what that essentially means is it suppresses your appetite. And the other one is when you're awake, it makes you hungry. However, when you have sleep-related problems, those hormones can then be secreted at the wrong time. And so there is this obesity and diabetes and everything that's associated with poor sleep that we're now finding out there's a great link to. So
that's very amazing. It has something to do with obesity.
Yes, and they're actually trying to find drugs that mimic these chemicals in the brain for obesity to try to shut down that drive to eat. So
yeah, I mean, when they can get the drive to eat cut off by a pill, that whoever invents that pill is going to be rich.
Oh yes, and as we know, obesity is a huge problem in the United States right now, and I saw something on TV the other day that said that it's just a growing problem and that it's actually becoming, in my mind, probably one of the #1 killers in the United States. So.
Well, it brings on diabetes and heart disease and sleep apnea.
Correct.
I mean, it results in sleep apnea.
Yeah.
Well, let's talk about the different kinds of sleep apnea. I mean, there's the and before we do that, I had one other question I have to ask you. So it's the fascinating thing that we have what's called sleep paralysis. Tell us about that.
When we go to sleep at night, the brain, when we get into dream sleep, has a receptor in the central portion of the brain that sends chemicals down to our brainstem. That actually causes us to have a relative paralysis. So we don't wake up in the middle of the night and act out our dreams. Some people who have what's called REM behavior disorder actually don't have that connection, so they may get up and beat up their spouse or jump off a balcony or throw chairs or run around the room running from whatever's chasing them in their dream.
In their dream.
And it can be very dangerous to those that are in the bedroom with them and themselves.
And that's why nature made us have this paralysis,
right,
so that we can't move during our sleep.
Right.
But there's something that happens, and some people don't have that paralysis.
Well, for the most part, when we wake up, we don't directly wake up out of REM sleep, and there's usually a quick on and quick off with that. However, in sleep deprivation, that's one of the common times that actually sleep paralysis can occur. So you wake up out of dream sleep and you lay there, you're able to hear things, you're able to sense things, but you're not able to move your arms and legs for a period of time. It can be very scary.
Because your body has turned off these things to protect you from sleepwalking.
Right. It's associated with other disorders, insomnia, like I said, chronic sleep deprivation. It's most notably one of the four things in narcolepsy, which is a disorder where you have sleep attacks during the day.
So what are the four things in narcolepsy? One is
narcolepsy, which is the sleep attacks during the day, cataplexy, which is very highly associated with, in general you can't have cataplexy without narcolepsy, and the cataplexy is you lose muscle tone. It may be just the droop of the face. A lot of times it's bilateral loss of your major muscles like your arms or your legs, usually brought on by emotion, either happy, sad, you know, screaming, those kind of things. Then there's sleep paralysis, which we talked about, and hypnagogic hallucinations, which are things that you get ready to fall asleep and then you start imagining or visualizing these things. And I can't remember the painting that's out there, but there's a painting of somebody laying on a bed and there's these demons above them and looking down on them, and that's supposed to be a adaptation of a hypnagogic hallucination. But you can also have hypnopompnic, which means those hallucinations actually occur upon awakening and not when you go to sleep, but that's not necessarily part of the quadrat. Or
So what we're really talking about is, this is not just pulmonary medicine, this is psychiatry, this is neurology, because all these neurologic things are happening. And when it's working good, we fall asleep, we become paralyzed, we lay there quietly, we rest, we where does the dog chasing the cat in his sleep come about? You know, you can see the dog running in his sleep, thinking about it. I mean, he's not completely paralyzed.
Well, and I honestly can't answer that question other than there is that disconnection, meaning my dog, my wife used to think she was having seizures all the time because she would lay there and her legs would twitch and just go like crazy. But that's that disconnect between that sleep paralysis that we get when we have dream sleep that occurs.
So there's that dog going out. You can just see that cat in the distance going, ooh, ooh, ooh. Our dog does that. Love that. Well, patients who use a CPAP machine when they sleep love the feeling that a good night's sleep brings. But they also may have things they don't like about having to be hooked up to it every night.
I've been doing it 6 years, and the only time I stopped was when the mask finally broke apart, and I needed to remask up, because that's the only break in the cycle of usage I had. But I'm not a diehard user. Like I said, when we go vacation, I don't take it with me, and when we go sailing, I don't take it. It's not at the vacation home or at the lake home or anything. I don't have two of them. I was waking up just dragged out, and so at that point he said, maybe we want to try a sleep study, and we did it at the Brookings hospital. It's an overnight stay. Technician observes you during a night's sleep without any apparatus and so on and so forth, and then in the middle of the night you're awakened, and after all the probes and things have been actually attached to you, and then they start attaching the apparatus and strapping an apparatus on your face to start increasing the pressures, external pressure. It's just pushing high pressure into your body. Through that analysis, they figured out that I needed 16 pounds of some odd value anyway, and that's the setting of my CPAP machine at home. My snoring was so aggressive that it just stopped my air waves, or air passages, and I was actually holding my breath. The noise of the thing, the burping, and the ill fit of I don't think they have that down pat. I've tried a new face mask as of recently, which is less intrusive over your face, but it just goes to the nostrils and part of the mouth. That's lent itself to be much more comfortable and less cumbersome for sleeping, because you do want to lay on your side at times, but you're tethered. When you miss it is when you go on vacation, where there's no place to plug a CPAP in, or the machine breaks down, you just haven't had time to fix it, a mask problem or so on and so forth. There's always this, I call it the dull headache wake up. It feels like you haven't gotten adequate sleep, kind of like you're staying up too late, or you watch TV too late and got a lack of sleep. So it gives you that feeling. You don't really notice it until you look down throughout the day or something. You'll see that you just lost a little energy. But the thing I noticed is that the first time I ever slept breathing through my nose. I was always a mouth breather, and I always had awakened with short, choppy breaths, almost like a panting. And when you're on the CPAP, you get these long, drawn-out, almost like ocean waves coming in, and on a peaceful flow, so you have these long, drawn-out breathing rhythms, if you will. And I think that lends itself to a better sleep. And also the machine sounds like an ocean coming through. It's the comfortable, cyclical white noise back there that puts a baby to sleep, you know. It's got all these positives for decreasing heart disease, and also that you're going to get a restful sleep. You know, I was being awakened during the night through my sleep apnea a little less than 100 and some times a night. So if we can take those episodes away, and the chart shows that you're getting a much more restful sleep, my mind feels better, my head feels clearer, and the heart, there's that benefit. And like I said, it's about like running. You don't feel the benefits of running or walking on a daily basis until you receive it down the road, where you have a healthier heart and healthier lungs, or any of the the vices we have. Stop smoking. Oh, I just feel really great the day I stop. No, you don't. You feel great in the benefits of the health down the road a ways when it pays the benefits of just a better quality of life.
Better quality of life. That's what we're going for on this. So he has a CPAP machine. Let's talk about what he has that causes him to have the CPAP machine. I mean, what is sleep apnea?
Okay. Well, most people feel that it's related to being really short and really overweight, but I can tell you I have plenty of patients in my clinic. Even, for example, my brother-in-law, he's a few inches taller than I am, probably a few pounds lighter, who has obstructive sleep apnea. So you don't have to be 4 foot tall and 500 pounds to have it. There's a genetic component. There's a component with you where your jaw is positioned according to the rest of your face. There's the large tongue, the soft palate where you have the uvula that can be too long, the anatomy back there for the tonsils.
Right, I had one guy's uvula that kept flapping right in front of his airway. I mean, and he had it removed. The problem was solved.
Yeah. So all of those things can contribute. What it is just airway obstruction, and what happens is during the day we're awake, we have control, but the minute we go to sleep and relax, that crowding and everything shuts off, and then the brain isn't allowed to get adequate sleep. So.
How much of it is nose architecture? I mean, people have a broken nose, and the midline separation, the septae, is shoved to the side. How often is that the problem?
A lot of it is a problem. For example, the patient that was just on said that he was a mouth breather. That just tells you he has a lot of nasal obstruction, which allows him to breathe through his mouth. Well, the mouth was meant to eat, to drink,
and not
to get rid of emesis or vomit, you know. To speak. It wasn't meant to breathe, and that's why when you and I get a cold, we wake up with a sore throat in the morning. It's because that wasn't the mechanism meant to breathe. So if the nose doesn't work, then breathing doesn't work. So fixing the nose is very important.
So it's really an airway that's open. We don't have it. If we're heavy, sometimes that airway is floppier. If we're older, that gets floppier. Right. If we have that genetic build that gets floppy, then we have it. But that's not all. Oh, go ahead.
I was going to say, I have a neck collar that's 16.5 inches. In men, that puts at risk for obstructive sleep apnea alone. Women, 15 to 15.5. So it doesn't take a huge neck in order to have a component of obstructive sleep apnea.
I have a 16.5 or a 17. Yeah. So
we're at risk.
We're at risk. Yeah, same. Well, but that's not just all of it, is it? There is also, that's the obstructive kind. Now there's this other kind, this central apnea. Tell us about that.
Central apnea just means that in some patients, for whatever reason, their brain stops functioning when they go to sleep at night. And that little bit of control that we have that allows our brain to breathe when we lose consciousness actually is lost. And so the brain will stop. Most of those patients either have a genetic condition, sometimes seen in pediatric patients. Other times it's usually, at least in the adult population, related to congestive heart failure.
So when I have a patient, sometimes it's just old, but I'll see them do what is called Cheyne-Stokes breathing. And that's interesting. Cheyne-Stokes breathing is they'll breathe heavy for a while, and then it'll slow down, and then they'll pause for a little bit, and then they'll start breathing heavier, and then they'll come up again, and they'll breathe heavier, and then they'll go down, and they'll pause. And neurologically, I know that means the brainstem is intact, but there's some other things, sometimes metabolic, sometimes just age. but they have this chain stroke breathing. Is that anything to do with central apnea?
That's a component of central apnea. For example, if you take your typical sleep apnea patient, you put them in the sleep lab, you start them on a CPAP machine, which opens up the airway and allows them to breathe. Some of them have CPAP-treated emergent, or they break out and cause central apneas. For some reason, the brain's just used to not breathing in the middle of the night, and so it stops on its own. However, if you allow them time, those will go away. On the other hand, you get the patients with congestive heart failure or some neurologic conditions such as brain tumors, and they hyperventilate until their brain says, hey, we've blown off too much carbon dioxide, and they stop breathing until that carbon dioxide builds up, and then they start breathing again, and they breathe faster and faster and faster until they hit that threshold, and they slow down and slow down and slow down and stop breathing.
And so that's one kind of central apnea. Now, I've heard that there's like less than 1% is the pure central apnea, 85% is the obstructive kind of apnea, and the rest of the 15% or 14% is a mixture.
Right.
And when do we see that mixture? In the elderly with heart failure, that kind of a
that kind of situation. And that's just what we call complex sleep apnea, which some people believe is real and some people don't believe that it's real. So, I mean, depending on who you read. But some people, they have a component of obstructive apnea and central apneas, and you have to use a little different device other than a CPAP machine sometimes to treat them. So.
Okay, now that comes to the other question about treating them. I mean, let's talk about CPAP, let's talk about BiPAP, and let's talk about non-CPAP methods to treat. Let's talk about the non-CPAP first.
Non-CPAP, the first thing that a lot of men will come to me and say is there's no way I'm wearing that machine.
Yeah, I've heard that.
So you can send them to the ear, nose, and throat doctor. And what the ear, nose, and throat doctor can do, they can straighten the septum, which we've talked about. They can get rid of the adenoids, which live behind the nose. They can actually shrink down the back of the tongue with a little bit of radio frequency ablation that kind of shrinks the tissues. They can cut off the soft palate and the uvula. They can remove the tonsils and try to rotor it for the most part to get it cleared out.
And that works how many times?
It's 30 to 80% effective depending on what you look at and which textbook you read. And a lot of it has to do with the anatomical obstruction because, as we've talked, it may be the nose, it may be the soft palate, it may be the tongue, it may be the neck with redundant tissue. So you could go through the procedure, which, there's 10 days of healing and pain associated with it. A lot
of misery in those surgeries, unfortunately.
Right. And then next thing you know, you still need CPAP therapy. So you have to have the right candidate for it. And some people who have horrible sleep apnea, a mixture of procedures such as CPAP and oral surgery is sometimes helpful.
Yeah, well, I mean, that even if you have the CPAP and it's still not working well, sometimes you do the surgery and then it allows it. There is one patient that said, oh, I have perfect solution by a jaw apparatus that I put in. It brings my jaw forward. The problem goes away.
You can buy those over the internet. You can see them on TV at night. Essentially what there are is a mouth guard that will either pull the tongue forward so the tongue doesn't obstruct, or it tries to pull the jaw forward so these muscles underneath your neck that tether that airway are pulled forward. The best ones are actually a dentist. You get referred to a dentist that makes these oral appliances.
Right.
They hook to the teeth on the upper and lower jaw, and there's a headgear associated with it that pulls the face forward. And slowly over time you tighten it until you get rid of the obstruction. It's usually beneficial in patients with mild to moderate sleep apnea, but I've seen some people with severe sleep apnea that were intolerant to CPAP use it.
Can you predict who will do well? I mean, is people with the jaws that go back, or no? You can't. You got to go to the dentist, got to have it checked out.
Right.
Or you could just do the CPAP and see if it works for you.
Right, but a lot of times where we use it is people say, I'm not wearing CPAP, number one, or they say, are there any other options, and we'll send them to the dentist. The key there is if you really want to try to obliterate or get rid of sleep apnea, is if you do the UPPP, or the oral surgery, or the oral appliance as they call it, you should always redo a study on them 6 to 8 weeks after they've been treated.
Oh, so now, and that UPPP is uvulopalatine
Pharyngoplasty.
Pharyngoplasty, meaning you cut all that crap out of there.
Roto-rooter is actually.
Roto-rooter. It makes more sense. UPPP.
Yep.
Standing for roto-rooter.
Yep.
So there you have it. Those are the things that you can do surgically. Well, what about? Okay, I won't take the CPAP, but I'll be willing to try oxygen at night.
Oxygen is kind of the Band-Aid. If you have somebody that has sleep apnea and needs oxygen on top of their CPAP, there's usually a cardiac or pulmonary problem. Most of the patients we send to the sleep lab, if somebody does a screening oximeter where they put the clip on the finger, they send you home, and it shows that you have low oxygen at night, and it's suggestive of sleep apnea. If you actually treat the sleep apnea, the low oxygen levels go away. So giving them oxygen at night may help them feel better in the morning. Mentation may be a little better. The headaches might go away. But it doesn't fix the problem of the airway closing off.
But it may be the only thing I'm going to be able to do for this person.
And it may be, but you have to look at oxygen probably won't prevent them from having atrial fibrillation. It may not prevent them from having congestive heart failure, heart attacks, sudden cardiac death, strokes, all those things that we're now finding out are associated with bad sleep apnea.
Right now, in other words, we're saying bad sleep apnea can bring on, let's say that list again.
Atrial fibrillation.
Which is this irregular rhythm that really brings on some heart failure. I mean, but it is a consequence of weakening heart from this
too much pressure. And, you know, there's a lot of science behind sleep apnea where they're looking and saying there's all these chemicals and hormones and everything that the scientists can measure that contribute to the diabetes, the uncontrolled high blood pressure, the irregular heartbeats. It just doesn't have to be AFib. That's probably the most common. There's associations with sudden cardiac death. There's associations with heart attacks, congestive heart failure, pulmonary hypertension, which is high blood pressure in the lungs, strokes, Alzheimer's disease, memory loss.
Memory loss. I mean, that's the biggie.
Yep.
Well, I mean, we need to talk about how to recognize it, and we also want to talk about BiPAP machines in a minute.
Okay.
We have a break here. There are some who normally sleep just fine, but then they put themselves into situations that interfere with their usual sleep patterns. It may be a job or travel that causes them to deal with sleep problems.
I started traveling internationally for electronics in '91, so that's 20-some years ago. And I've traveled close to 140 days a year some years. Right now it's maybe in the 90. Not all of that is international travel, but I probably today make 6 to 10 trips a year overseas. In March I went to Asia for a week or two, got back for 3 days, and then I went to Europe for a week. And so you do that kind of jumping around, and it takes longer than a week home to readjust. It takes like a month. It seems like if you're in country for a week or so, you're just starting to get adjusted when you start to pull out and go somewhere different. I think it probably has to do with things like stress and other things going on in your life, when just how quickly you're able to get back to a repeatable schedule. Not being mentally alert as much as you're used to, or not feeling the same. It's some people may call it a headache. I think I would describe it as a buzziness when you really get tired, and you're running on a few hours of sleep because that's all you're able to get. And so why is it that sometimes it's easier and harder? What is a bad trip? A bad trip is not one night like that, but you go to bed at 10 or 11 o'clock, and 2 or 3 hours later you're up and you can't get back to sleep again. And by the time you're feeling tired, you're out of time, and so you need to go about your day. If that goes on for 2 or 3 days, then that gets to be very hard. To say I starve myself or fast on the plane isn't right, but I'll eat a little bit. But I won't consume a lot of food. I won't be full. And it just seems to me to make it easier to readjust. If you're really tired, take 10 minutes or 15 minutes, something like that. I find that to be very helpful. It's hard to explain when you've pushed past the point of your body being able to stay awake, and hitting a wall or something like that might be an analogy. You physically cannot stay awake any longer, and if you get to that point, it's not a good place to be. But I've seen people lay down for a 15-minute nap, and 4 hours later you're like, well, I haven't seen them for a while. Then that's a bad spot too. If you've taken a 4-hour, kind of a nighttime rest in the middle of the day, those people, and I've done it once or twice when I've gotten home, that that throws the whole thing out of balance. It's this staying awake until it's nighttime wherever you're at is a key part of it. And then, you know, it's been helpful for me. Taking a sleep aid isn't necessarily, from my perspective, a bad thing, but don't test it out as you're taking off to go over wherever. Try it at home and give it a go.
That was great. Let's talk about the things that help with people who travel and the things that interrupt your normal sleep. I will commonly, and I hardly ever prescribe the common benzodiazepine kind of sleeping aid, but I do when people travel. And sometimes I'll use melatonin as well. I'll prescribe that. What is your take on the best thing to do for a person who goes to China and then back and then Europe? And I mean, what would you advise medicinally?
Well, traveling east for whatever reason, and I'd have to pull out the textbook again and read about it, is much more difficult than traveling west for whatever reason. And some of it has to do with at about 8 or 9 o'clock at night when it starts getting dark, we have our melatonin onset. And melatonin is a chemical released in the brain that allows us to feel sleepy. And then when we wake up in the morning, about 2 hours before we get up, our body's at the lowest temperature of the day. And those two things are correlates to how well we sleep at night. So when you travel east or west, if you get outside of those realms too much, where your body temperature isn't falling in that pattern or your melatonin comes on too early, then you run into this problem of insomnia. So sometimes using sleep aids like he does to try to help get sleep, try to keep your normal pattern as much as possible, but obviously with business and vacation, you don't want to be sleeping during the day and awake at night. So it's very difficult.
Yeah, the melatonin, I read one article, the melatonin is a reasonable thing, but I always am concerned about it because I know sometimes it comes from cow pituitary glands, and that worries me because is there danger there, a risk of infection? What have you heard?
I think the melatonin supplies that we have are fairly normal. A lot of them are plant melatonin. Rosarum is a melatonin receptor that's a prescription drug you can give that's supposed to act like melatonin. The problem with melatonin you get over the counter is not FDA regulated.
And so you don't know what dose you got.
Each pill might have a different dose, each bottle may have a different dose, so you're really not sure of the effect. But for the most part it's fairly safe to use and may help people with some mild form of insomnia.
Right. Well, let's talk about insomnia. I mean, a lot of people talk about the pills that they can. I mean, I've got a problem with insomnia. I can't, and I need to have these pills, and they get caught in a lifelong habit of taking one of those benzos at night. What's your take on that?
Well, the most important thing to remember about insomnia is the majority of them are what we call secondary insomnia, meaning there was a trigger. You have the test the next day, you got the important meeting, so you stay up all night and you start thinking about it. Or maybe it's a life-changing event that you just can't get out of your mind. Well, pretty soon that behavior is cemented into your brain and now becomes a primary problem because it was years ago. So the thing is realizing what it is and what the problem is, and the next thing is making the bedtime routine as best possible.
That's sleep hygiene.
Yes.
But I like your first comment, and that is if you've got a psychological problem, and many people do, and sometimes it's just depression, has nothing to do with your the fact that your kids are struggling through college or anything else. It's just that you are depressed, and that's a common side effect. So treatment for depression is not the benzos, it's the antidepressants and counseling.
Right.
And counseling is important. Okay, now...
And some of those medications that you would use to treat depression, like trazodone, which is a fairly good drug, doxepin, which is a tricyclic antidepressant like amitriptyline, even though doxepin is the only one that's been FDA approved. Some of the other antidepressants have more sedative effect. Taking them at night may be helpful to treat, to kill two birds with one stone.
I like citalopram, generic, $4. Helps a lot of problems. Take it at night. Over time, it helps. Okay, so but I interrupted you.
Okay, I was just going to say some of the medications that you said. Okay, what can we use? The traditional ones are obviously the benzodiazepine receptor drugs, like you hear about the Lunestas and the Ambiens, or Zolpidem, which is the generic name of Ambien. Those are good drugs to use, number one, because they're very short-acting, they're fairly clean, plus they don't really have a lot of the respiratory depression effect that the benzodiazepines have. However, there's some habit-forming nature to them because you have this chronic insomnia, and next thing you know, you take it and you rely on it. And it's more of a psychological issue that you can't get rid of it.
Dependency is big, and I think over the long haul, the people do get depressed with these medicines. I much prefer the tricyclic or the trazodone, which we use safely in the nursing home, so it's safe.
Right.
If I'm going to use a medication.
The problem we have to remember about those medications, though, is they don't have really a sleep aid in them. Most of the properties that those medications actually affect are the histamine receptors in our brain. So it's like taking Benadryl. And you know what happens when you give Benadryl to kids or even some of our older patients. It can actually have a paradoxical effect. It can they can be delirious and confused and be more awake than they are, so you have to be careful with those medications.
I do know, though, that in the geriatric literature, almost everybody comes down to, well, after a long time taking care of the elderly, when it comes to a sleep aid, trazodone.
Right.
And that's one of those drugs. Of course, drugs. I'd rather not use medication, and I would discourage it if you can. What are the non-medicinal methods to improve hygiene and to improve sleep?
Going to the bed at the same time every night.
Getting up
out at the same time every day. Establishing a routine. If you have a very disorganized routine, just like you would have it in your normal daily life, you'd be confused, you'd be stressed. So getting that routine down, good. I jokingly said on a previous visit there's two things that go on in the bedroom. Number one is marital relations, and the other is sleep. The radio, the TV, the books, the magazines, the computers.
That should go out the door.
Now
I remember you saying that.
Now that being said, if you don't have any problems with going to sleep, there's nothing wrong with sitting down and reading a book until you're tired, as long as you set your bedtime. But if you get into that good book and you're reading and it's now 1 o'clock in the morning and you got a meeting at 6 and you're tired the next day, then that becomes problematic. And so the people that turn on the TV and try to go to sleep and then they get engrossed in this movie and it's 2 o'clock in the morning, that obviously becomes a big issue.
Yeah, I ban TV for my patients at night. Get them out of your bedroom. That's not where we watch TV. You watch TV downstairs. If you're ready to go to bed, turn it off and come upstairs.
A lot of my patients say, I'll go to bed and I'll lay there for 2 hours. And the minute I go sit in my chair, I fall asleep. Well, that's because whatever has caused them to have their sleep onset insomnia has now made the bedroom a horrible place. So you got to make that place pleasant. If you lay there for more than 20 or 30 minutes, get out of bed, go find something boring to do, go back to bed. If you're up till 3 or 4 o'clock in the morning, still get up at that regular time. I can guarantee you'll be tired the next night and you'll go to sleep a lot easier.
Yeah. So getting up at the same time. Why do our college kids or high school seniors on break sleep so late? And what do you recommend for these people who sleep till noon when they can?
We know that in kids, especially adolescents, that there is some abnormal sleep behavior. It's not that they really need any more sleep, it's just their propensity to stay up later at night, so then they sleep. It's in theory what we call a delayed sleep phase syndrome. So their bedtime now becomes later, so they still need their 8 hours of sleep, so that means they got to sleep in later. The problem is it becomes disorganized because Monday through Thursday
they got to get up.
They got to get up, and then Friday is bad. So the old adage that, oh, you got your 8 hours of sleep, you need to get out of bed is some kind out the window. In general, there's nothing wrong with letting your adolescents sleep for 10 hours or whatever.
All right.
But you just want to make sure that they get a decent sleep. So
important. The Brookings Health System has a sleep lab to help find ways to deal with the variety of sleep problems our patients have.
Brainwaves on a computer screen, and the specialized ability to interpret what they mean. These are two of the most important aspects of a sleep study. Janie Isham understands this clearly. She is the point person for the Brookings Health System Sleep Diagnostics Lab, and she explains what patients can expect when here.
They can expect to come and spend the night in a comfortable setting. Number one, we try to make it as comfortable and home-like as possible. They're going to have multiple sensors on their scalp and on their face that record their brainwave activity. They'll have electrodes on their chest to monitor their heart rhythm, a sensor on their finger to watch their oxygen level. So we monitor a variety of things during the night.
Patients at the sleep clinic see no injections or invasive procedures. They're simply hooked up to monitors with tape and adhesives, and one of the most important monitoring devices records what's going on in the brain during sleep.
I'm looking at their brainwave activity, which actually tells me what stage of sleep they're in, which is very important to know because we go through multiple stages throughout the course of a night's sleep. I would be monitoring their heart rhythm to make sure that that's normal. Their breathing, whether their airway is partially closing off or completely closing off, whether they're stopping breathing, be monitoring their oxygen level to make sure that that's adequate.
Isham says sleep apnea, which is an interruption in breathing while sleeping, is one of the sleep disorders she looks for, and it's a condition that can be serious.
There's a lot of comorbidities and problems that we're finding that link sleep apnea that's untreated to diabetes, heart arrhythmias, stroke, high blood pressure, memory problems, just functioning, depression. All of those can be attributed to undiagnosed sleep apnea that's not been treated.
Understanding the intricate connections sleep has with the body's overall health is rewarding to Isham, and she feels gratified when able to help patients get a good night's sleep.
It is very interesting, and we are monitoring so many different things, and it's very gratifying to have someone come in and be able to help them and, just, I don't know how to say it, improve their overall quality of life and be able to make a difference. And that's what I like about it.
Well, the sleep studies have really been refined from what we did before to what we're doing now. What goes on in a sleep study?
Well, essentially they bring you into a room that's set up like a hotel room. So it's to make your bedroom look like your bedroom. It's not a hospital room, so it's supposed to be warm and comfortable. The bed's supposed to be comfortable. They take some electrodes, they strap them to your head, they put some things up by the face to measure airflow.
Doesn't sound very comfortable.
No, they put bands and things around your chest and abdomen to see if you're breathing in the middle of the night, so you can look for that. They put things on the arms and legs, but most people go, wow, there's no way I'm going to fall asleep using this. However, I can guarantee you that I'd probably say 85% of patients that fall asleep readily at home will have no problem falling asleep in the sleep lab. Usually because they're so chronically sleep deprived that they just get in the sleep lab, they're hooked up and they're asleep anyway. Those that don't, we usually prescribe a sleep aid for them, usually to get them asleep because we don't want to waste their time.
Does it ever mess up your results using a sleep aid?
No, not really. I think the bigger issue when you're looking at pure obstructive sleep apnea, now if you're doing it for insomnia reasons or narcolepsy or something like that, maybe not. But in general, if you're doing it for sleep apnea, you don't want your patient up till 2 o'clock in the morning and only have 4 hours to do your titration.
My wife tells me that if I lay on my back, particularly if I've had 2 glasses of wine, I'll snore for sure. Mm-hmm. But if I'm on my side, I'm okay. How about just sleeping on your side as I know that in the sleep lab they say sleep on your back so that it'll obstruct.
Right.
I was going to ask you, sleeping on the side, is that
There are some people that just have pure positional sleep apnea, that the only time they have sleep apnea is when they lay on their back, and part of that is because gravity now takes all this stuff and pulls it backwards. And some people only have it when they're on their back in dream sleep, because that REM or dream sleep is when they become paralyzed, so everything becomes weaker.
Right.
So yeah, we really want to get people on their back and into dream sleep when we diagnose them, and we want to get them there when we treat them, because if they do get into that position at home, we want to make sure that they're adequately treated.
Right.
The problem is if there are plenty of people that sleep on their back and have it, they sleep on their side and they have it. Sedatives like whether it's trazodone or Lunesta or Ambien or the benzos or narcotics, any of those that blunt your respiratory drive, wine, can actually cause you to obstruct your airway, and so when you lay on your back, you might snore more than usual.
So that's one of the leading questions is, suppose a person is a heavy drinker and a smoker. Does that really set them up for this problem? And smoker is the question.
The heavy drinker, yes. The smoking, not necessarily. In patients with COPD who have
COPD, which is
chronic obstructive pulmonary
disease
from smoking, can have an overlap syndrome where they have sleep apnea and COPD, but smoking in general may not be a huge risk factor for obstructive sleep apnea in general.
So that brings us to the issues about restless leg syndrome. And we ran through all of these other weird, rare kind of things earlier on. But what about restless leg syndrome? That's pretty common, isn't it?
It's very common, and people usually don't realize it, and people don't complain about it unless you ask them specifically. But there are some 3 criteria that tell you have restless legs. Number 1, there has to be a nocturnal or nighttime, bedtime type onset. So the minute you sit down in the chair to watch your evening TV or read your book or whatever it is, you get this uncontrollable urge to move your legs. You get these creepy, crawly, wormy feelings. And what happens is you get up and move and it's relieved. Those are in general the 3 criteria that you look for restless legs.
Now there's a different syndrome that's like restless leg called, and I'm trying to remember.
Well, there's periodic leg movement disorder.
Yeah, right.
Periodic leg movement disorder can be independent, or it can be associated with restless leg syndrome. 90% of people with restless leg syndrome have periodic limb movement disorder.
So explain to, you explained restless leg. Let's explain periodic limb.
So you have the restless legs, you finally get to sleep. What happens is all it has to do is the big toe can twitch just a little bit. And there's this cyclic pattern where the big toe twitches frequently within a 90-second period. And if that causes the brain to go from an area of sleep to a quote-unquote arousal or awakening, then it's considered a periodic limb movement disorder or periodic limb movement arousal. And so those can be equated to poor sleep in the morning, or poor sleep and daytime sleepiness as well.
So, I mean, these are funny things that happen. Do we have any understanding of why they occur, this restless leg or even this periodic limb movement?
No, they think the restless leg and the periodic limb movement disorder happen to be related to dopamine depletion in the brain, which is a chemical in the center part of the brain associated with Parkinson's disease and things like that. And so that's why some of those medicines that are used for Parkinson's disease are actually used to treat and seem to work for restless legs.
Do you see people who have restless legs as a clue that they might get Parkinson's or not?
I think there is some association with it, but I don't know how strong it is.
Yeah, I would say that there's a lot of people who have it and they won't go on to get Parkinson's, so don't worry about getting Parkinson's disease if you have it. But there is a correlation. I know that people who have Parkinson's have it a lot more.
Right.
So what do you do for it?
Well, you can, some people just suck it up and bear it, and they just try to move their legs and they kick them a lot before they go to sleep. Other people try the dopamine medications out there like ropinirole or I think the other one's Mirapex. I can't think of the generic name for it. There's some of these anti-seizure meds that we use to treat neuropathy are also very important, such as Neurontin is one of the drugs.
Gabapentin.
Yep. You can use the benzodiazepine drugs. Even some of your sleep aids like your Lunestas and your Ambiens may be helpful. And narcotics such as your hydrocodone and Percocet and those kind of things, if you need to treat two problems, are sometimes helpful.
The bad news I know about this is that in some people, using an SSRI, a serotonin reuptake inhibitor, which is wonderful medicines for depression, can sometimes worsen restless leg. Yeah. Why would that be?
It has something to do with the serotonin pathways in the brain. I don't know that I know that off the top of my head, but it's very commonly seen in those groups of medicine. So sometimes you have to switch them to more of the norepinephrine type drugs for antidepressant, such as I think Effexor is one of those.
Yeah, that one. Wellbutrin.
Right. The other thing to remember for the lay people out there, iron deficiency anemia has a very
big cause for this.
Right, and so you always should check an iron and a ferritin level in patients with restless legs, because sometimes you fix their iron deficiency in their restless legs.
So why is that, Tony?
I don't know why that is either.
We don't know.
No, it has to maybe do with some iron deposition in the brain and you know, those are things that I studied for sleep boards and then went in one ear and out the other.
Well, no, I remember reading about it. I've studied it, and I can tell you this. Don't know why.
Yeah.
I think it just means that if you've got restless leg syndrome, make sure your doctor checks you for iron, particularly if you're a menstruating woman. Yeah. But it might be that you're a colon cancer bleeding person who restless leg is a clue to check for colon cancer, and it's time to get your colonoscopy. Yeah. I know that's an odd thing to bring up here, but it's important.
You got to look into the cause of iron deficiency as well, obviously, but you can kill two birds with one stone. So.
I'd like to talk about naps just a minute.
Okay.
I had a nap today. Okay. I think we missed out in the U.S. The Europeans have it. They take a nap at noon or after a big noon lunch, noon dinner, and they take a 1 or 2 hour nap, and then they go back to work at 3 or 4 in the afternoon, and they work till 7 or 8, and then they party a little bit, and they don't have such a big supper.
Right.
What do you think of that?
Naps are okay. There's nothing wrong with naps. It's kind of like the TV and the book in the bedroom. As long as they're not interfering with your daytime or your nighttime sleep, then there's nothing wrong with a nap. The problem is some people take those naps, and if they have bad sleep at night, they'll get a 15-minute nap. They'll wake up, they'll feel refreshed, not a problem. But you take that hour or 2 hour nap, then you wake up with what's called sleep anergy, where you wake up and you just feel worse than you did when you went to sleep.
And you can't sleep that.
Right. Your body requires 8 hours, 7 to 9 hours of sleep. So you sleep 2 hours during the day, you're not going to have as much luck going to sleep.
I've heard less than 30 minutes is the ideal time.
The key.
Tell us, and very quickly, alpha or delta sleep versus REM sleep. What are they?
Delta sleep is what we call slow wave sleep. In our younger years, we have probably about 25% of our night is slow wave sleep. The problem is, as we get older, that slow wave sleep goes away, and we don't really know why.
And do we need it? We must not.
We do in some respects, because if you and I decided to go out and party for the next 3 nights and do whatever, boat, just go sweep the streets, what we would do when we go back to the sleep lab and have a sleep study, we would repay that delta sleep back if we had it. We would also repay our REM sleep back, because our body craves those things.
So what my dad said years ago was that we actually have a sleep deficit and we need to build it up, and that's why we should sleep longer on the weekends?
Some people say that you need to repay that sleep debt back in order to feel better, but you can about imagine somebody who's had sleep apnea for 30 years and not been treated. There's no way you're going to
get that back, is it?
But we know that if, for example, we pulled an all-nighter in medical school, that next night, instead of it being 90 minutes for our first dream cycle to hit, it may come within 15 or 20 minutes, and that we might have, instead of 20% of our dream sleep in a night, it may be 30 or 40%. So we got to repay it back some way. Nobody really understands exactly why, but...
Very good. There's an old German folk tale about Undine, a beautiful young water nymph who fell in love with a handsome mortal. Her lover promised, "My every waking breath is a testimony of my love." And yet later, Undine discovered the mortal to be unfaithful. Her father, the nymph king, then placed a curse on the fickle lover, making his breathing a conscious and not automatic process. Thus, if the mortal should fall asleep, he would forget to breathe. Well, eventually Undine's cursed lover succumbed to complete exhaustion, fell asleep, and died. The name Undine's curse was first used in 1962 to describe 3 brain surgery patients who died resulting from that loss of autonomic drive to breathe during sleep. But the name subsequently came to be used to describe a rare congenital syndrome in babies with a similar inadequate breathing drive. More recently, experts advised the name Undine's curse be dropped, since the word curse implies wrongdoing and guilt to the parents of these unfortunate babies. I think this story better relates to the broad category of conditions called sleep apnea, which involves troubled breathing while asleep. The word apnea actually means no breath or breathless. Less than 1% of patients with sleep apnea is due to weakness of the brain-controlled autonomic drive to breathe, called central apnea. 85% is due to floppy, fatty airways that obstruct breathing, called obstructive apnea, and the rest is due to a combination of central and obstructive causes called complex apnea. Whichever the type, sleep apnea can be dangerous, even deadly condition, resulting in excessive daytime sleepiness, depression, anger and irritability, memory loss, and even strokes. What's more, prolonged low oxygen causes increased risk for high blood pressure, congestive heart failure, heart attacks, and sudden death. Clues for this serious condition include high blood pressure, morning headaches, sudden awakening with shortness of breath, observed spells of breathing cessation, especially in people who are obese, loud snorers, smokers, or sedated by alcohol or sleeping meds. Then again, sometimes there is little warning, and sleep apnea is a silent killer. If you or your spouse could have sleep apnea, see your doctor. You wouldn't want to have Undine's curse. Take-home thoughts on that one.
If you think you have sleep apnea, you should probably see your primary care physician, have some screening tests done, see a pulmonologist, get sent to the sleep lab, because I can tell you that it's probably one of the most undiagnosed conditions that we have out there, that just about everybody that comes into clinic, we could screen and send them to the sleep lab.
Very important words. Well, that closes our show on sleep medicine. I sincerely thank our studio guest, Dr. Anthony Herricks of the Avera Medical Group Pulmonary and Sleep Medicine, Sioux Falls, for visiting with us about this very important topic. Aldous Huxley noted, "That we are not much sicker and much madder than we are is due exclusively to that most blessed and blessing of all natural graces, sleep." Well, until next time, stay healthy out there, people. And thank you.
Thank you.
Funding for On Call is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
and by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding provided by Dakota Care, Regional Health, the Brookings Health System, Dr. Mark Bubach with Dakota Allergy and Asthma, the South Dakota American College of Physicians, and Swiftel Communications. Closed captioning for On Call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation.